6 p.m. right here, 10 p.m. in Berlin. Shall we? Let's get started.
Yes, let's do it.
Oh, okay. So, good evening, everybody. Welcome. My name is Sergio Viana. I'm a musculoskeletal radiologist in Brasilia, Brazil, and I will be your host for this session. I am one of the producers of the Advanced MSK platform, whose focus is on continued medical education on MSK imaging. We feature bilingual content like case presentations, webinars, courses, and the like. So if you haven't done so already, please consider following our Instagram account, which is Advanced MSK. So without any much ado, let me introduce our guest speaker. He needs no introduction at all. Kay Hermann is a household name for those involved with MSK imaging around the world. A distinguished scientist who co-authored several seminal papers and is a professor at Charité University in Berlin. But beyond his remarkable scientific achievements, he's a kind and dedicated friend. For you to get an idea, it's Friday night, already past 10 p.m. in Berlin, and this man of science is online for this webinar just to help a friend. So it's my pleasure and my honor to invite Professor Dr. Hermann for his lecture. Kay, if you please.
Yes, thank you, Sergio, for inviting me. We talked about it already in the last year, and it's my pleasure to present today. And I will give a lecture on imaging of arthritis on an easy level. I try to make it practical. I will also show you some practical cases with the app Berlin Case Viewer that I developed together with my team, and we collect a lot of very interesting and stunning cases. You will see it. And so if you have feedback in this webinar, you can raise your hand. I see already one colleague is raising the hand. Maybe we address this question at the beginning, and there's also lower down, there is the chat box and also the question and answer option. So you can ask your questions in these two options, chat box and question and answer feature. And we try to address your questions after the lecture. I will soon share my screen and will present my slides. So attendance today is worldwide, and I'm really happy for so many of you for attending. It's really my pleasure. And of course, my special greetings are going to the radiologists from Brazil, as this is organized out of Brazil, and I'm really happy to contribute to this activity. Okay, so let's get started. And now I also can have a screen share for you guys. And here we are. Okay, so yeah, that's the title of my lecture. Okay. So when you try to read images of the hand and feet, especially X-ray images, there are a lot of joint diseases that you may encounter. And usually this is a very big field, and you are somewhat puzzled about the many diseases. And usually if you try to read them up, these are more or less very large books with lots of pages. So most of people give up trying to understand joint diseases. So the idea today is not to detect each single of these joint diseases. As you see here, there are 15 examples, but rather to do a distinction between two groups of joint diseases. And the first one is inflammatory joint diseases, and the second one is degeneration. So if you make the distinction between inflammatory and degenerative joint diseases, that would be a good start, and then you can build on this knowledge. Okay, so here are the three concepts of the joint diseases. So we will talk today about rheumatoid arthritis as the prototype of synovial joint disease. We will speak about psoriatic arthritis, and we will also briefly speak about osteoarthritis. So when we speak about rheumatoid arthritis, we need to think on the anatomy of the joint and what happens in this disease. So if we look at the joint, we can see there's a hyaline cartilage covering the bone. That's the articulating bones. And the hyaline cartilage is at the end. And then we also have the joint capsule. That's the green line here. That are the ligaments. And the joint capsule is the red line. And you can see there is this gap between the attachment of the joint capsule and the hyaline cartilage. And this area here is bone with a little bit of periosteum exposed to the inner cavity of the joint. And this is where the trouble starts for the bone, where the erosion will form. Here you see a view that the orthopedic surgeon has sent me from his operation, where you can see there is proliferation of the synovial tissue. And this is called pannus tissue. So this proliferation of the synovial membrane happens inside the joint. And as the area here is not protected by the cartilage, we call it the bare area, then this is the site of the least resistance. And in these areas, we have the ingrowth of the pannus into the bone, and it comes to destruction. And this destruction later on leads to erosions. And as you see, the erosions are at the lateral edge of the joint. That means on the margin of the joint, and therefore these erosions are called the marginal erosions. So this is a very typical sign in all forms of arthritis, especially in rheumatoid arthritis. And you see it here in the pathophysiological drawing, but it is also evident on the X-ray. You can see here, these are 3 MCP joints. That's the second MCP joint, the third one, and the fourth one. And we see there is this destruction in the bone at the lateral part of the bone. Also here we see there's no longer a clear contour of the bone. So this is a very large destruction, and all this is destroyed by pannus tissue. You don't see the pannus tissue, but you see the results. And the joint space here is very preserved. That means that the cartilage inside the joint is not so much destroyed in this phase. Only later on, if there's subluxation and ankylosis, the joint space gets narrow. Rheumatoid arthritis is also it's a multilocular disease. So you see it's not only one joint affected. There are, in this example, all 3 joints affected. So that is in most of the cases there's destruction of more than one joint. So let's look at some practical cases. I've prepared some cases, and I would like to show you some of them in the Berlin Case Fair app. So here I prepared some cases just for this lecture. And can you still see my screen, Sergio? Yes, I think yes.
Yes, I can see there is some problem. People are saying that they are not can get in. I don't know what's the problem is. I'll try to show while you continue with the lecture.
Okay. If so,
it's perfect.
Is the problem with the sound or with the screen share?
No. Sound is good.
Okay, cool.
Something about the access.
Okay, cool. Okay, so we have here this patient, it's a 47-year-old woman, and this patient reports about pain in the joints for at least 25 years. So it started when she was rather young. And when there's movement in the joints, it's going a little bit better. And there's also morning stiffness of 30 minutes. Morning stiffness is a very important sign for a rheumatologist, and it's usually a sign for an inflammation rather than degeneration, because in degeneration you don't have morning stiffness, you have rather pain worsening over the day. But at the end, sometimes it's rather difficult. And there's also positive evidence of rheumatoid factor and anti-CCP antibodies. So already from the laboratory tests, it is very likely that there is some inflammation over here. So if we now look at this one hand of the left side, usually I recommend looking at both hands at the same side. So if you have a PACS workstation, you should try to look at the left and the right hand together in order to see asymmetry. So if you look closely, there are two things that you can see. At first, you try to look at these images from a global view. So you look at the mineralization of the bone and if the joints have a symmetric appearance. So the axis of these joints are good. They are not malaligned. There's maybe one flexion deformity here in the DIP joint of the small finger on the right. And otherwise, these joints look okay. Then you check the mineralization, and here I would say that there is some osteopenia next to the joint on both sides. So that is evidence here. And also, if you look at the thumbs, then you can see that there's a difference between the right and the left and the right thumb. So here you see the joint space very well preserved. Here you can see there's a joint space narrowing, and also there are these cystic changes in the bone that are an indirect sign of erosion. Next, also, if you look at the wrist and the carpal bones, you can see the carpal bones are well preserved here. And also the joint spaces, they look nice. But on the other side, we see decreased joint space and joint space narrowing and even malalignment of the bones. So that is what you can see both on these fingers. Also, we did make X-rays of the feet, and here on the feet, I don't know how who already sees something, but if I enlarge it a bit, you can see that these are not normal feet. We see the mineralization is okay, but you have to look carefully at all the joint spaces. They are okay from the first till the fifth. And then if you compare it to on the left side, you see there's this destruction going on here. There's a cyst-like change, and we have this kind of defect in the bone. So you don't see it. It's not that it's a true defect, but you see the cystic change, which is an indirect sign of bone destruction. So it's a rather it's a typical site for rheumatoid arthritis. Also, if you look at the big toe, you can compare it left to right, and on the right side it looks fine, but on the left side you can see that there's a large defect of the bone, and there's this contour that is smooth and clear over here, and also on the lateral side that's no longer here. So there's a large destruction of this bone, and we were even able to show that in our markings, because in the Berlin Case-Sphere app we have the option to highlight the features. So if you learn on your own, you can get these drawings and you see the different descriptions of the changes. So you see juxta-articular osteoporosis as a marker, and also you see cystic changes that are indirect signs of bone destruction that you can enlarge and study at high detail to find out about how we are doing the report in our institution. You see there is this lucency here in the bone. But this is an early case. It's not an early case. There are already erosions, but it's a case with osteopenia next to the joint. I'm showing you the second one, where we have in a 59-year-old female with recurring episodes of pain and swelling at the wrist and fingers. And there's also swelling at the time of presentation and elevated CRP. And I think it can be clearly seen by all of you already that there are some destructions. We have here, if you compare it side by side, see there are destructions of the MCP joints, the second and the third on both sides. So this is a symmetric manifestation of the disease. We also see the destruction of the carpal bones, which is symmetrically involved, more or less. And if we take a closer look, we can see that this is exactly how I described it in the lecture slide. We have the lateral contour. We have over here the defect in the defect of the cortex of the bone. It's a large hole in the bone, and there are a lot of these lesions over here. So you see joint space narrowing, you see the erosions, and also at the wrist, you see multiple of these erosions. You need to look very closely and also see the joint space narrowing, and the distal part of the ulna is no longer there and is missing. Okay, so these are two examples of rheumatoid arthritis. Even if you look here at the feet, we see the erosions. They are not so much developed as compared to the hands in this particular patient. Okay, so continuing with the lecture slides, we are going to our next disease, which is psoriatic arthritis. And in psoriatic arthritis, the pathophysiology is even more complex as compared to rheumatoid arthritis. In psoriatic arthritis, we have an inflammation, especially at the antithesis. The antithesis are the ligaments and attachments of the joint capsules next to the joint. So the synovial lining, which is the red line, is well preserved at the beginning. We have the pathologic processes going on outside of the joint. So the green line, the ligaments are now inflamed. I made them a little bit thicker. And the next, what's happening, the next stage is then reactive inflammation of the bone, which we call osteitis. So that means because of this anterior inflammation, we have inflammation inside the bone next to the attachment of the antithesis, but it can spread into the entire bone, and we call that osteitis. And this bone inflammation then leads to reaction at the periosteum. So at the edge of the bone, we have then suddenly a reaction which is then leading to calcifications and proliferations of the periosteum. So you will see that on an X-ray image. And later on, as a fourth step, only then we see the synovial inflammation, and we may see then also synovitis as we know it from rheumatoid arthritis. So it looks the same if we have already synovitis, but it is different if you look on X-rays or if you catch the disease early where we only have the enthesitis. If you compare that with the X-ray finding and MRI, we can see this finger here, where there is a skin reaction, the reddish skin lesions compatible with psoriatic disease. We see also nail changes, and this very same finger is enlarged here in this X-ray. We can see there is this ill-defined margin of the bone. So the regular bone has a sharp contour. In this inflamed joint, we see there is irregular contour of the bone on both sides, and this is called periosteal reactions or spiculae. And we see also the destruction of the bone due to the synovitis, which is the erosion that we see on the marginal position. So we have this combination of proliferation and destruction, which is very typical for psoriatic arthritis. If you compare it with the MRI, we can see that indeed we see the enthesial inflammation in this high resolution image. So we see the joint capsule over here. So the joint capsule is attaching to the bone. And here, this side, there's only few inflammation. So there's only less gadolinium enhancement. But on this side, we have a lot of inflammation. So we see this very intense inflammation at the periosteum and also at the attachment of the capsule. And this can lead to a full osteitis. So you see this entire bone is inflamed. So psoriatic arthritis is defined as an arthritis, but it's in fact a disease that affects entire bones. So it's really much more aggressive to the bones and joints compared to rheumatoid arthritis. So here's some test case for you. If you compare left and right, what would you say, which is the affected side? You need to look carefully at the width of the joints and also at the contours of the bone. And if you compare it, you can see that here we have fluffy contours of the bone compared to the normal side. So we have very intense psoriatic manifestation over here, and we have periosteal reaction. If you perform an MRI in this patient, we can see that there's an entire inflammation in the ulna, in the radius, in the lunate, and there's also synovial inflammation in some of the joints. Again, I would like to present some of the cases that we have collected in our app for you to learn in more detail. So this is the third case I have prepared. It's a 47-year-old male patient. So it's a man, and he presents with swelling of the joints of the hand and feet, and it's getting worse. And also he reports of psoriasis of the skin. CRP is not so much elevated. So if you look here, what can you see? I think what you see is there's no demineralization at the joints. So the matrix of the bone looks okay. In order to really find out what you can see, I recommend comparing it to the other side. So if you have the option on your packs to have both hands together, you should do that. And if you do it, you might be able to see the difference at the third MCP joints. So if you look at the third MCP joint on the right and on the left, you can see that on the right, it looks very nice. And on the left, it is fluffy. We see here, there's ill-defined contours. Also here, the joint space is well preserved. There's no erosion, so it's in very early stage. And if we look further and compare also the wrist, so you see on the right, the joint contours and the joint space at the wrist, they are okay. Also on the left side. But if you look closely on the contour of the bone, of the shaft of the first metacarpal bone, the trapezoid bone, scaphoid bone, and if you compare it to the other side, you see there is this bony reaction over here that we call periosteal new bone formation. We also made it visible in our app, so you can see it in detail on yourself. We have made it with blue markings, so you see there is this proliferation over here, even there, and it's a very subtle finding. So it's, let's say, 4 different sites. I don't know how long you need in order to detect it, but you need to compare it left and right, and you really need to take your time in order to find it out. So let's check on the feet of this patient. So the left foot and the right foot. So what can we see here? I think we should enlarge it a bit in order to check what's going on. And it's always important to compare. So first thing, what is evident is the soft tissues. So the big toe is really a big toe. So there might be soft tissue inflammation. And if you look at the MTP joints, you can see, for instance, that if you compare the right side with the left side, there's something missing on the left side, marked here in yellow. So there's some erosion on the left side. I will enlarge it a bit more. So you need to take a closer look, and you see there is the smooth contour of the bone is no longer there. It would go like this. It's not here, so there's an erosion. And also what you can see is some defect over here. And if we compare it with the MTP joints second to fourth way, you see the normal contours here, and there are all over bony proliferations at the basis of the basal phalanges. And there are also some joints already with erosions. And at the big toes, we have new bone formation and also soft tissue swelling. So you see in psoriatic arthritis, it's all happening at the periosteum and at the edge of the bone. So you need to look for changes at the edge of the bone, and they are coming before there's an erosion. In this example, we already have erosive destruction, so bony loss due to the synovitis, and also proliferation due to enthesitis. So these are the two components in psoriatic arthritis. So let's continue with the slides. And I would like also to speak a little bit about early diagnosis. I showed you 4 examples, 4 cases only based on X-rays. I explained you what happens and what are the effects of these changes on X-rays. But what can we see in the early phase of the disease? And in the early phase of the disease, it's very unsatisfactory what we can see on radiography. So you see, these are examples of early RA, early psoriatic arthritis, and early osteoarthritis, and more or less these X-rays look all the same. And I think Sergio will agree that you look at a lot of X-rays every day, and most of them are normal. So it is really a very difficult business to find out on arthritis on X-rays. So for the early detection, we use a different method. So we use either ultrasonography or MRI. And these 2 methods are very useful for early detection. So if there's a certain suspicion that there's some arthritis, usually the rheumatologist or the radiologist performs ultrasonography of the joint. And if it's not conclusive, he might perform MRI, or if he is not trained doing ultrasound, he's also doing MRI. And we can see there is a tenosynovitis seen on ultrasonography. We can see synovitis with power Doppler activity and even erosions. And similarly on MRI, we see the erosions of the bone, we see the synovitis, and we see also synovitis and tenosynovitis in our patients. Our range of findings is rather broad on MRI. We see these changes that we can explain based on the pathophysiology, which is synovitis with inflammation inside the joint capsule and in the inner layer of the tendon sheath. We call it tenosynovitis. There is a finding called bone marrow edema or osteitis that is happening in some of our patients, especially those who are severely infected. So if you see bone marrow edema next to the joint, you can, you know that this joint is truly inflamed, and erosive damage will soon happen. Erosions are the defects of the contours of inside the bone, and sometimes we also see inflammation outside of the capsules, like in this patient with periostitis in psoriatic arthritis. We can try to do a differential diagnosis with the MRI. Here are the three groups: rheumatoid arthritis, psoriatic arthritis, and osteoarthritis, or other degenerative joint disease. And these are nice examples based on MRI, where you see the different patterns, the pattern inside the joint with erosions, the pattern outside the joint with osteitis, and the pattern just subchondrally with some cystic changes and some marrow edema. But usually it is not so easy to make the differential diagnosis based on MRI. This is better being done on X-ray. And I would like to stress this by this example of this 68-year-old lady, where there was a lot of inflammation going on at the distal ulna, also inside the radiocarpal joint, at the intercarpal joint, scapholunate joint. And there's a lot of synovitis also going on the dorsal aspect of the carpal bones. And this would be easily diagnosed as rheumatoid arthritis. But if you have an X-ray available and you look at it, you will see there's a malalignment in the joint. So this joint has some inflammation because this ligament is torn, and there's an increased width of the joint between the lunate and the scaphoid. There's even subluxation of the lunate, and you see a lot of soft tissue calcifications over here. And this leads you to the diagnosis of chondrocalcinosis pyrophosphate disease, or CPPD. And without this X-ray, this patient was being misclassified. And this is something that you have to take in mind, that you need to try to look at the X-rays. So if you are in an MRI facility, patients should bring their X-rays, and you should briefly look at the X-rays in order to check what's going on there. That's my approach, making the best diagnosis. Okay, going further in our lecture, I would like also to make you familiar with the different patterns of joint destructions. So I explained it already in the initial phase of the lecture. In rheumatoid arthritis, you have a manifestation of the disease mostly in symmetrical fashion. That is, and it's mostly affecting the MCP joints. It may also affect the PIP joints, but rather never affects the DIP joints. You need to be aware that MCP joint is also at the thumb, and this interphalangeal joint is more or less similar to a PIP joint. So also sometimes rheumatoid arthritis happens at this joint, and then you should also be very carefully evaluating the styloid process of the ulna, because we have a lot of destruction going on here. And this is mostly not due to synovitis, it's due to tenosynovitis of the extensor carpi ulnaris tendon, which passes the styloid ulna in a very close fashion. Looking at the next disease, which is osteoarthritis, I didn't show you so much examples of osteoarthritis, but osteoarthritis mainly affects the distal interphalangeal joint. In the hereditary form, it is mostly affecting the second and third DIP joints. We call it Heberdine osteoarthritis of Heberdine's type. We also have a type where the PIP joints are affected. That's the Bouchard osteoarthritis, and of course the CMC1 joint, the carpometacarpal joint, is frequently affected, and this is called Leeds arthrosis or osteoarthritis of the thumb base. Sometimes this joint, this small joint between the trapezoid and the scaphoid, is also affected by osteoarthritis. So this is also a joint more or less typical for osteoarthritis, not so much for rheumatoid arthritis. Okay, so going next to psoriatic arthritis. In psoriatic arthritis, different types of joint involvement are described. So the transverse type is depicted here, where we have an affection of all the DIP joints. We also see sometimes a ray-like affection of the joints, which is called Ray type psoriatic arthritis, it should not be mixed up with dactylitis, because in dactylitis you also have inflammation of the entire soft tissues. So it's just a joint involvement pattern. And there's also the mixed type where we have the transverse type and the axial type in one patient. But I can tell you, and I also showed you the example, most of the psoriatic arthritis patients, they have a completely mixed up pattern, and it's not according to the textbooks. So psoriatic arthritis is a very, it's not a symmetrical disease for sure, and it's very fluctuating and jumping from one joint to the next. Comparing these three diseases to CPPD, we have a clear pattern of joint involvement at the MCP joints in CPPD, and also calcification osteoarthritis at the wrist and the distal ulna. So that's very typical. And there are rare diseases like hemochromatosis, where we have only involvement of the second and third MCP joint. But this is a really rare disease. Not so rare is a disease called gout. Gout is usually a monoarticular disease. Only in advanced stages, it's polyarticular, and there are some target joints for gout. One of them is the thumb base joint, the CMC1 joint, but sometimes it's also jumping. You can have affection of MCP joints, and you can also have multi-locular affection in patients with gout. So it's similar to psoriatic arthritis, as there's no real rule where there's manifestation of gout. Okay, so if you take all of this into consideration, you are now able to make distinctions between two sets of diseases. So we have the degenerative set of disease, where there's joint space narrowing and osteophytosis. I didn't explain it in detail. And there's this inflammatory type of joint diseases, where there's erosion and destruction, malalignment, joint space narrowing, and sometimes also periosteal proliferation. And with these two groups, you already capture a lot of diseases that you might encounter on X-rays of the hands and feet. There are some remaining diseases where you need to read up in the books, because these are rare diseases, and I will show you some examples at the end, if you like. But first, I would like to show you more examples of rheumatoid arthritis and psoriatic arthritis, and also with correlation to MRI. So here's the fifth case that I would like to present. And again, I show you the example with left and right together. You see, these are the X-rays. Let's check on the patient. It's a 55-year-old woman with long-standing pains and swelling of the wrists and fingers, and also of the toe joints. And there's also marked morning stiffness. And anti-CCP body rheumatoid factor are positive. So it's a very likely diagnosis of rheumatoid arthritis. So let's have a look that we can see. We see that we have X-rays of the hand. We also have X-rays of the feet, and also we have an MRI of one of the hands, so we can compare what we see on X-rays and on MRI. If we look first at the MCP joints, we see the joint space is well preserved. There's some cystic change over here, and but this is not yet an erosion, because the contour of the bone is well preserved. If we look at the carpus, we see there is joint space narrowing in almost all the joints. There's some big destruction over here, and there are more cystic changes in the trapezoid bone, and also here's some defect of the bone, so this is an erosion. And so already based on the X-ray, we know this is an arthritis with erosions. Comparing it with the MRI, we perform a T1 weighted MRI scan. I didn't go into the protocol. We can do that in another talk, but you can see the MCP joints more or less look okay. There is some signal alteration in the third MCP joint. So this is a spin echo sequence with 3 mm slice thickness. If we use a three-dimensional sequence with 1 millimeter slice thickness, a so-called wipe sequence, we can now see that we have here an erosion going on that we would expect in this third MCP joint. So this cystic change is an indirect sign of this erosive destruction in this particular patient. So X-ray only shows you the tip of the iceberg. Here we have enhancement after gadolinium injection, and we also see another erosion over here that we did not encounter in this position. And also, if we look at the wrist, we see there is a lot of inflammation going on in the wrist, and also these destructions that we did foresee here, they are visible. My last example is this case number 6. It's a patient 50 years old with already known diagnosis of psoriasis of the skin, and she has swollen toes. So if you look here, we can see that indeed we see this reddish skin lesion. We have also nail nail changes, and we see there are some toes that are thicker than the others. So for instance, if you look at the third one, that's a normal size. Here we have an increased toe and thickened toe, and also the fourth one. So these are called dactylitis. So these are dactylitis manifestations, maybe also here. So it's sometimes difficult based on clinical grounds. You need to palpate in order to see if there's pain. And if we compare it with the X-ray, we do not see so much on these X-rays. They rather look okay. So there's no periosteal reaction. So not all the patients with psoriatic arthritis show periosteal reactions. And if we then compare it with the MRI scan, we can see that there is some osteitis in these bones. You see the distal phalanx, the middle phalanx, and the basal phalanx. They all have bone marrow edema or osteitis, mostly the middle phalanx and the distal phalanx. And we also see this capsular enhancement outside of the capsule. So this is a very good example of psoriatic arthritis. And it's prevalent in the second and fourth toe, same toes as were inflamed in this patient. So it's a psoriatic dactylitis in this patient. Okay, going further, there are only a few slides left. I said you need to read up the rare changes. So some, let's say, food for thought, if you want to go deeper into these diseases. Rather rare disease is Scleroderma, or CREST is also some form of scleroderma where we see flexion deformity. They cannot extend their fingers. They have juxta-articular demineralization. They also have trophic problems at their fingers. So the bones are slowly going away, which we call acro-osteolysis. So you see the distal tips of the fingers, they are no longer there. And they also lead to interstitial calcinosis in patients with scleroderma. With patients with lupus, they may also see problems with the distal ends of the fingers because they have a vascular disease that leads to acro-osteolysis, similar to scleroderma. What's typical for lupus is the deformity of the fingers, but no erosions. So they have joint deformity and flexion deformity, but joints are well preserved. It's called a non-erosive arthritis. And this is typical for lupus. And I showed you already some example of gout. So here's the complete list of findings. We have soft tissue calcifications in gout, which we call tophi. We may also see lysis of the bone, inside the bone or the edge of the bone, which looks like an erosion, but it's due to tophus inside the joint. And at the end, it leads also to a destruction and erosion. CPPD are already explained. Typical are the calcifications at the triangular fiber cartilage. We might see large osteophytes at the MCP joints that usually are not present in a regular osteoarthritis, and we also see sometimes osteoarthritis in the scaphoid aspect of the radiocarpal joint, where the scaphoid is subluxed and is pressing into the bone and leads to this typical osteoarthritis. So if you see this large defect in the distal radius and you do not see calcifications, you still can assume it's an is in patient with CPPD, but this one here has some calcifications. And my last example is the hemochromatosis, where we see these large osteophytes and orthocystic changes in this only the second and third MCP joints. So if you see that, one should be worried and maybe perform genetic tests or liver biopsy. Okay, so to summarize this lecture, I think I could show you that it's important to understand the pathophysiology of the diseases, because if you understand it, it's very easy to access X-rays and MRIs, CT scans, ultrasounds of all sorts, because you already understand the disease, and it's now easy to detect changes in the imaging. MRI and ultrasound are used for early detection, but not so much for differential diagnosis. So I would recommend you use X-ray along with MRI and ultrasound. So at least ask your patients to bring X-rays if they were already done. And you could also see how much you can see on X-ray if you look carefully. And also it's very easy and cheap to monitor the disease over the course of time doing X-rays. Final slide. On this app that I used it on my Mac, but it's also available on iPads, iPhones, and also on Android phones. So you can have a look. Most of these cases are available in our library. And we have also free cases of the month, and we will expand our library soon with new cases. So thank you very much for your attention, and I hope you have some questions that I'm happy to answer together with Sergio.